Extension for the Global Health Institute, and also an assistant professor of practice within the HPS department. And I'm very happy to be joined here by so many people and for another Global Health Speaker Series. And we are very, very fortunate to be here, to be here joined by this excellent scholar. And I will let Maya Block introduce her speaker. But thank you everyone for being here.
Thank you. Good afternoon. I'm Maya Block-Ngaibe, a PhD candidate and PhD student and member of the Global Health Alliance, a student-driven organization aimed to enhance students' knowledge of how public health functions in a global context. And I'm excited to partner with the GHI to introduce Dr. Magdiel Habila, who will be presenting COVID-19, HIV, and cervical cancer when infectious disease problems become chronic disease problems and you live in Nigeria. Dr. Magdiel Habila is the Associate Director for Outcomes Research Oncology in the Center for Observational and Real-World Evidence at Merck. Prior to the start of her career at Merck, Dr. Habila completed her Master of Public Health and Epidemiology in 2019, her MS in Health and Pharmaceutical Outcomes in 2022, and PhD in Epidemiology in 2022 at the University of Arizona. During her time as a doctoral candidate, Dr. Habila was an NIH Fogarty Research Fellow with the Global Health Equity Scholars Program. She completed a mixed method study examining barriers and facilitators to cervical cancer screening for women living in with HIV in Jos, Nigeria, under the mentorship of Professor Jonah Musa at Jos University Teaching Hospital and Dr. Madivanan at the University of Arizona. Dr. Habila's interests are in cancer epidemiology, specifically breast and cervical cancers in women of African descent, and in the ways in which pharmacoeconomics can be applied to addressing cancer-related health disparities. Welcome, Dr. Habila. The floor is yours.
Thank you so much, Maya. And thank you everyone for being here to hear my talk. I really appreciate you taking time out of your busy schedules to kind of spend some time with me. And so as Maya already mentioned, I will be presenting on cervical cancer, HIV, and COVID-19, and the intersections between infectious diseases and chronic diseases. And this talk was titled the way it was because I really want us to consider as public health professionals how these two silos, as we discuss them, infectious diseases and chronic diseases, relate with each other, and all of the ways that we as public health professionals can bridge the gap between the two in order to serve communities that might be lost otherwise. And so, what is happening? Sorry. All right, for an outline, I'll give some very brief high-level introduction into cervical cancer, HIV, COVID-19, and Nigeria. There's a lot of moving parts, so please stay with me. Then I'll discuss the objectives. I'll give some overview into the specific population that we looked at in this study and the clinic that serves them. Then I'll talk about the results, the methods and the results from the study and everything that we found, along with the discussion, future directions, and some concluding thoughts for us moving forward. And so to get started about cervical cancer, it is a chronic disease that is caused by persistent infection with human papillomavirus. And so this is the first intersection between infectious diseases and chronic diseases that we'll discuss throughout this talk. HPV is the most common sexually transmitted infection in the world, and it's spread by skin-to-skin contact. And most infections will clear within a healthy body in 2 years. Thankfully, HPV vaccination reduces rates of infection. The most common strains of HPV are HPV 16 and 18, and all effective HPV vaccines target these strains specifically, as well as others. And so HPV has an affinity for the cells in the cervix, as demonstrated on this graphic on the right. We see that the cervix is located right at the top of the entrance into the uterus from the vagina. And so the cells in that particular area are really susceptible to human papillomavirus, which kind of leads to cervical cancer. And so cervical cancer, being a chronic disease, has a long latency period, the time in which healthcare professionals are able to screen for the disease and intervene in order to avoid further progression. The most common cervical cancer screening mechanism is the Pap smear. However, in recent years, the Pap smear, in addition to HPV DNA testing, have become the gold standard of care for cervical cancer screening. In many low resource settings, however, they still rely on visual inspection, either on its own or aided by acetic acid or Lugol's iodine, or both in some cases. However, the screening itself is being done, the procedure typically is the same, where the woman goes into the clinic and puts her feet in these little stirrups that's shown on the picture on the right, and then a speculum is inserted into the vagina, and then a sample is taken from the cells on the cervix. These cells are then assessed in order to identify, if any, atypical changes in the cells in that area. And so there's some potential outcomes of Pap smears. You'd either have a normal Pap smear, which is what you would want. You can either also have atypical cells of unknown significance, which require follow-up, usually in a short period of time. There's also the possibility of having low-grade suspicious lesions, which also require follow-up in a specified amount of time, and then high-grade suspicious lesions. And these can usually be intervened upon and the cells be removed at the time of screening if it hasn't progressed to be too significant. At this point, after high-grade suspicious lesions, there's full-blown cancer. And cervical cancer, like other cancers, is staged in 4 stages, ranging from being highly localized to being spread to distant parts of the body. So even though we have access to HPV vaccination that reduces the rates of infection and very effective cervical cancer screening mechanisms, cervical cancer remains the 4th most common cancer among women. In 2020, over 600,000 women were diagnosed with this disease, and over 300,000 women died that year. And so we see in this graph that it comes 4th after breast, lung, and colorectal. When we examine these rates more closely, we see that most of the incidence and mortality from cervical cancer are happening in low resource settings. And so the graph is the same one that you saw on the previous slide, but just kind of turned to the side and then zoomed in to look at low and high income settings. And so we see that most of the incidence of cervical cancer, 85%, occurs in low resource settings, and 90% of mortality happens in low resource settings. And some of the reasons for this observed disparity are as follows. The first is with primary prevention. And so in high income countries like the US, we have access to HPV vaccination, which, as I said, impacts the rate of infection, and then also infection with HPV, and then also goes to have long-term lasting protection from HPV. There's also access to HPV DNA testing and Pap smear, which is the gold standard for cervical cancer screening. There's also access to effective treatment for cervical cancer if the disease is diagnosed. And there's also health insurance to kind of provide financial support for paying for all of these things. And there's an asterisk next to health insurance, because as we know in public health, not everyone has access to all of the same things. And so for those who are able to have health insurance to cover these costs, this can be a very effective way to preserve life long-term without having to have increased mortality from cervical cancer. In low and middle income countries, on the other hand, there's limited access to HPV vaccination. In our case study of Nigeria, it costs about $180 to get the HPV vaccines to completion, which is a significant amount of money for anyone, really. There's also limited access to Pap smear. And so, as I mentioned, most healthcare settings still rely on visual inspection, either alone or aided by acetic acid or Lugol's iodine. Additionally, this limited access to HPV vaccination and limited access to strong cervical cancer screening mechanisms leads to oftentimes late-stage diagnoses. And these late-stage diagnoses are often very difficult to treat, even if women do have the financial resources to do so. And so keep all of these kind of facts about cervical cancer in the back of your mind, because now we'll quickly transition to a brief overview about HIV. So HIV is another common sexually transmitted infection. The global incidence of HIV was between 2.5 and 2.6 million people per year, and that was in 2015. About 75% of new cases that year were in sub-Saharan Africa. The global prevalence of HIV is incredibly common at about 400 million people, and that was in 2015. So it's more now. I wasn't able to find more updated statistics published. And this is interesting to note that about 42% of women living with HIV are receiving antiretroviral therapies. And these ARTs are important because they suppress HIV's replication in any human's body. So the fact that fewer than half of the women who need ARTs in order to go about healthy functioning are not able to access them is a significant kind of burden for us in public health. And so this map shows exactly what I just mentioned, but kind of in pictures. So we see in the darker blue regions indicate lower HIV incidence, whereas the red regions indicate higher HIV incidence, sorry. And so the highest incidence, as I mentioned, tends to be in sub-Saharan Africa, with the peak being in the southern regions of Africa. This map shows the number of people receiving ARTs, and so we see a similar disparity by country income, where higher income countries have the highest access to ARTs, while lower and middle income countries have lower access to ARTs, which again impacts the quality of life, care, and access to care that they're able to have while living with HIV. So now we have two things kind of floating around in the back of your head. You have cervical cancer, you have some high-level facts about HIV, and now we're going to look specifically at Nigeria. So Nigeria is a country in West Africa. It's home to over 230 million people, making it the most populous country on the continent. It's about the size of Texas land-wise. It's Africa's largest economy, with over 250 ethnic groups and 500 distinct languages spoken across 36 states and 3 major religious groups. So this is a very diverse region of the world with lots of moving parts that make tailoring interventions specific to cervical cancer or HIV a little bit challenging. And so to zoom into our topic, cervical cancer is the second most common cancer among Nigerian women. The incidence rate in 2020 was 18.4 per 100,000, which translates into roughly 12,000 new cases, and a mortality rate of 13.2 per 100,000, roughly 8,000 deaths in that same year. The risk for cervical cancer globally is 6 times higher for women living with HIV, and Nigeria has about 2 million people living with HIV currently, and about 3/4 of those people are women. And so you start to see how there's this kind of coming together of this high incidence and mortality from cervical cancer and this high prevalence of HIV. Cervical cancer screening, in spite of these things, remains really low throughout the country, with estimates indicating that about 20% of eligible women have actually been screened for cervical cancer. And these data are really sparse and need to be replicated in other parts of the country. So now we have some context about cervical cancer, we have context about HIV, and then we have context about both of those things in Nigeria specifically. So we're going to hit pause on this, and we're going to talk now about COVID-19. And so you can probably think back to where you were and what you were doing in March of 2020, when the World Health Organization announced that we were in an active global pandemic. If you were in the US like I was, we experienced these lockdowns, the closure of non-essential services, and these work from home practices, and we all discovered collectively that our only hobbies included eating out with our friends and touching our faces. However, the closure of these non-essential services had significant impact on cancer prevention and control services within the country. One study found that cervical cancer screening specifically dropped 94% after the initial lockdowns in 2020, and that screening rates have remained below 35% since then. And so not only did cervical cancer screening drop drastically, it hasn't recovered since, meaning that the impact of the closures that we all experienced in 2020 are still being felt today. And that hasn't even taken into account the missed diagnostic procedures and chemotherapy appointments. And we are yet to quantify exactly what that has done for cancer prevention and control in the US. Now, thinking more specifically about COVID-19 in Nigeria, the country experienced similar national lockdowns with shelter-in-place orders and the same closure of essential services. However, the impact was felt very differently. Limited telecommunications infrastructure made schooling and working from home extremely difficult, if not impossible, in some settings. And then that closure of non-essential services that keep showing up in quotes as a little bit ironic is that people were not able to go to business to provide for their family. And so these non-essential services were feeding families, and people were not able to do that. Additionally, there was insufficient personal protective equipment in healthcare facilities, which limited healthcare providers' ability to show up at work safely, but also limited the availability of healthcare services that people needed, including routine HIV care and cervical cancer screening. And to crown all of these things, there was no access to public transportation. And so even when people were allowed to be out and about to take care of business, they had to be able to walk to wherever they needed to get to, or they wouldn't have been able to do that. So if people weren't able to walk to the healthcare facility or walk to take care of business or provide food for their families, they wouldn't have been able to do that. And so we're posed with a question, which is, what do you have when you have cervical cancer, which is incredibly common among Nigerian women and requires consistent monitoring, and you have HIV, again, common among Nigerian women and requires consistent monitoring, and COVID-19, which disrupts routine care and brings socioeconomic challenges to management of health and general well-being. This is the question that our study sought to answer. And we tried to do that with two objectives. The first was to identify how many women obtained care before, during, and after lockdowns, and to describe their demographic and clinical outcomes in those periods. And the second objective was to describe clinical outcomes by number of visits before, during, and after COVID-19 lockdowns. Excuse me. Okay, so the rest of the data that we'll be discussing for the presentation were all collected in Jos, Nigeria. And Jos is the capital city of Plateau State, which is highlighted in pink on the right and is also my hometown. And so Jos is home to approximately 900,000 people. 50% of the women in the city are below the age of 64. This is important because 64 is the maximum age for cervical cancer screening. So 50% of women are eligible for screening, but not that many people have access to it or are willing to do it. Jos is served predominantly by Jos University Teaching Hospital, which is the primary teaching hospital in the state that provides access to a variety of healthcare services. But for our purposes, we're focused on the fact that they provide opportunistic cervical cancer screening, meaning that women don't have to be referred by a healthcare provider in order to be screened. They can just kind of walk in and say, this is what I want to do. And the data from JUTH indicate that about 2% of their patients are living with HIV, which makes the data from this healthcare facility really representative of the overall prevalence of HIV in the country. The APIN clinic, or the AIDS Prevention Initiative of Nigeria clinic, serves specifically people living with HIV. So all of the services offered at this clinic are tailored for this population, including theory-based health education, educating them about the importance of taking their ARTs, the importance of diet and exercise and other healthy living kind of tips and practices. They provide HIV testing and counseling. They provide lab services, CD4 and viral load monitoring. STI screening, tuberculosis screening and treatment, and they also provide cervical cancer screening. And in this setting, they use visual inspection with acetic acid and pap smear. And all of these things are free of charge to patients or of very low cost. And so I mentioned that we were going to be looking at demographics and patient outcomes before, during, and after COVID. And so on the top half of this slide, you'll see kind of two hard policy stops, if you will, that happened around COVID-19. The first was the international, I guess, lockdowns that we all experienced in March of 2020, where no one was allowed to leave their house or do really any social activities outside with other people in close quarters. However, they quickly realized, they being kind of leadership in the city and in the state, I think broadly, quickly realized that this was an unsustainable standard because people were unable to feed their families. And so these restrictions were then loosened such that people were able to leave home a couple days a week to go about business, to buy food, and to take care of kind of the day-to-day things that their family would need. However, after this loosening of restrictions, there was kind of this unstructured regression to the norm, where there were no additional policies put in place that restricted human movement in order to prevent the spread of COVID-19. But everything just kind of went back to normal. And so in order to capture these changes over time, we included in our study 6 periods. The first was to establish baseline, and all of the baseline included all of the women who were at the clinic between January of 2018 and December of 2019. We then split 2020 into 4 quarters. The first quarter to capture that initial global lockdown, the second to capture that loosening of restrictions, and then the last 2 quarters of 2020 to essentially identify what was happening in terms of human movement in relation to healthcare for the last half of 2020. And then our post-COVID restrictions period was in 2021. And I use post-COVID very loosely here because while we understand scientifically that COVID is still being transmitted person to person, there is not reflected in practice that this is the experience for people at this time. And so post-COVID does not mean that there's no more COVID in this setting. There's definitely COVID. It's just not interacting with the way that they live. So just keep that in mind. And so our data source was derived from 2 databases within APIN Clinic. The first was the HIV Clinic, which keeps longitudinal data for all of the patients that they see. And the second was the Cervical Cancer Screening Clinic, which identifies and keeps track of women who have been screened and the treatment that they receive if they need it. And so we abstracted data between January of 2018 and December of 2021 and merged those data from the HIV clinic and the cervical cancer clinic by their unique patient identifier that they have across the clinic. And the variables of interest that we kind of kept in mind for our analyses were the demographics, of course, including age, marital status, and level of education. With the HIV care data, we were interested in the patient's viral load at the different checkpoints across this time period, and then the HAART regimen that they were on. And then from the cervical cancer screening clinic, we were interested in their pap smear results and the number of clinic visits that they had over this period of time. We were interested in the research question and how these COVID lockdowns interrupted HIV care and cervical cancer screening. And so in order to be included in this data set, women had to have had both HIV care and cervical cancer screening between January of 2018 and December of 2021. So our exposure of interest was COVID lockdown period, which was really a proxy for time, as you, I'm sure, understood from the timeline that I showed earlier. Our primary outcomes were HIV viral load, which is measured in copies per milliliter of blood. We excluded extreme values. So that was anyone who had a viral load measured over 100,000 copies of milliliters per blood. And then our second outcome was pap smear outcomes, measured by the Bethesda classification. And I'll talk more about that in a little bit. The covariates that we were interested in were level of education, so no formal education, primary, secondary, and tertiary education, and then number of clinic visits, which we used as a proxy for access to care. And again, I'll talk about that later on. So as you recall, we had two objectives. The first was to identify how many women obtained care and to describe their demographics and clinical outcomes before, during, and after lockdowns. And so these two tasks that we had, which were to describe changes in demographics and to describe changes in HIV adherence as measured by viral load. And we needed to be able to identify both of these changes and in a cross-sectional way so that we could isolate specific visits. So as I mentioned at APIN, patients go there regularly for their routine HIV care. And so we were working with a longitudinal data set. And so in order to convert those longitudinal data into a cross-sectional data set, we identified a first clinic visit for each woman. And so this is not the actual first time that women went to the clinic. It was just the first instance in which they were interacting with a healthcare professional at the clinic within our time period of interest. And so whenever that first visit happened within our time period, they were then classified as being in the pre-COVID, one of the 4 quarters of 2020, or post-COVID type of world. If this is a little bit difficult for you to understand, here's a picture that I hope shows it a little bit better. And so on the left of the screen is a data set of 10 theoretical patients, all going to the clinic at different times and different numbers of times. And so in the dark teal is the first time that the patient went to the clinic. In the light kind of aqua color are the follow-up visits. And so we essentially ignored all of the follow-up visits and just isolated the very first instance within our study period that the patients went to the clinic, and we used those data for the following analyses. We identified the number of women who obtained care using descriptive analyses, as you would expect. And then we used linear regression in order to determine how average age changed before, during, and after the lockdowns, and to determine changes in average viral load for women who obtained care in those 3 periods. And so I'll explain kind of the results from this particular objective, and then I'll go and talk about the second objective and show the results from there. So this is the first half of our table 1. And the first thing I would like to highlight for you is that the number of women who obtained care between January of 2018 and December of 2021 was 2,304 women. So that was the number of women who obtained both routine HIV care and cervical cancer screening in our time period. I will also have you kind of pay attention to the average age at which people were coming into the clinic. And so you'll see that the women who came into the clinic in Q2 and Q3 of 2020 were younger than women who came in the pre and in the post kind of COVID periods. I'll also draw your attention to the HIV viral load. The women who came into the clinic in Q3 of 2020 had significantly higher viral load than they did in the baseline pre-COVID period. And then we see another peak, another increase in HIV viral load in the post-COVID restrictions period. I'll talk about why that is in the discussion section. And this is the second half of table 2. I want to draw your attention to 2 things that are kind of happening simultaneously in this pap smear section. So we see that in Q2 and 3 of 2020, the number of women who came in for pap smear at all was significantly low, with only 30 women coming in and all having normal results in Q2, and then the total of kind of 96 women coming in Q3 altogether. And this, for a clinic that usually serves hundreds of women per quarter, is significant. Another thing I would like to draw your attention to here is the increase in high-grade abnormalities. So prior to COVID, the women who were screened and had high-grade abnormalities was just 9 women. And then in post-COVID, there was 57 women who had high-grade abnormalities after everything was said and done with COVID-19. So this increase is something that we'll talk more about later on in the presentation, but it's definitely worth noting. And so for the second half of our objective, which was to describe how demographic and clinical outcomes change over time, this is our second table, and this table is a linear regression showing the mean difference in age for women who sought care at the clinic. And really all this is showing is that the women who came in Q3 really were significantly younger than the women who came in to the clinic at baseline. On average, they were about 2 years younger than the women who came in prior to COVID-19. Please note at this point that level of education and marital status did not differ significantly over time, and so we don't really talk about these, but level of education does come up as significant in later models. And so when we considered HIV and lockdown period, it's important to note here that compared to women who obtained care prior to COVID-19 restrictions, women who obtained care in Q3 of 2020 and post-COVID restrictions had significantly higher mean HIV viral loads during this study. And again, I'll talk about why that is later on in the presentation. And so moving on to our second objective, which was to describe clinical outcomes by number of visits before, during, and after COVID-19 lockdowns. We included all of the data for every woman. So if you think back to our theoretical database of 10 patients who came in different times, different number of times over our study period, instead of isolating kind of the dark blue initial visits, we used all of the data, and then we counted up the number of visits that they had. In essence, instead of comparing all of the women to each other, basically saying that they all had equal access to care, we wanted to compare women who had equal access to each other. Basically, what I'm saying is we wanted to compare all of the women who had only one visit to each other, all of the women who had 2 visits to each other, and all of the women who had 3 visits to each other, because we understand that the number of times you're able to get to the clinic indicates that you have increased access to the clinic. And so we wanted to be able to account for that in our analysis. And so our analysis was just a linear regression describing the average change in HIV viral load by lockdown period by number of visits. And so I'm going to show you 3 tables. The first will be results just for women who went to the clinic once at any point. The second table will be for the women who went to the clinic twice at any point. And then the third will be for women who went to the clinic 3 times at any point. And so among the women who only had 1 clinic visit, compared to women who had 1 visit prior to COVID-19 lockdowns, women who had 1 visit in Q3 of 2020 had significantly higher mean HIV viral load. Compared to women who had 2 clinic visits prior to COVID-19, women who had 2 clinic visits in the post-COVID restrictions period had significantly higher mean HIV viral load. And lastly, compared to women who had 3 clinic visits prior to COVID-19, women who had 3 visits in Q3 of 2020 had marginally higher average viral load. And we think that this was not really statistically significant due to sample size. If you'll notice, there were only 6 women in this category. And so those are the results of this study. There are a couple of findings that I would like to highlight and kind of discuss moving forward. So the first is that on average, women who obtained care between April and September of 2020 were younger than women who obtained care prior to COVID-19 restrictions. This is interesting to me, at least, because if you'll cast your mind back to a lot of the earlier messaging around risk for COVID-19 and who needed to be more cautious in their interactions with the outside world, if you will, we saw in the US that younger people were more likely to be out and about than older people who were perceived as having increased risk to COVID-19. And so it was interesting to me that we observed a similar trend in health-seeking behavior in Nigeria, where younger women, at least, were perceived themselves to be of younger risk and were able to go out and obtain care, whereas older women were less likely to do so. The second finding is that there was a significant decrease in the use of cervical cancer screening services between April and September of 2020. And this particular finding is significant because, as I mentioned earlier, women living with HIV have increased risk for cervical cancer. Additionally, there's evidence that supports that the progression from pre-cancer to cervical cancer is much quicker in women living with HIV. And so having an extended period of time in which women were unable to access screening could have untold impact for cervical cancer incidence and mortality in this population moving forward. The third important finding was that HIV viral load was highest between July and September of 2020, and then again after COVID-19 restrictions. Now, to refresh your memory, that was this table here where we saw the two peaks in the HIV viral load. And there are two reasons for this that we think, or suggestions maybe for things that were happening around this time. The first peak was likely due to delay in ability to access care. Now, if you remember, this was in all of those first clinic visits for these women. And so it's possible that women were seeking HIV care either for the first time or again after a long time. And so this delay in being able to access their HIV medication would have led to an increase in viral load, which then we saw in our data. The second peak that happened after the COVID-19 restrictions was likely due to decreased capacity in APIN for new patients. And so even though by this time life was kind of back to normal for most Nigerians, within the clinic itself, they were still adhering to the WHO social distancing guidelines. And so those distancing guidelines significantly limited the number of people that were allowed to be in the clinic at any given time, which then reduced the number of people who were able to be seen on any given business day. And so that decreased capacity, not due to an individual's ability to show up, but due to kind of policy recommendations that were put in place, impacted people's ability to get their ARTs that they needed to remain adherent to their HIV treatment protocols. And so we observed those two peaks in our findings. And the last important finding that I would like to highlight is that the number of clinic visits and when those visits happened significantly influenced HIV viral load. And there are two things that I wanted to call to mind with this particular finding. The first is what we would expect as healthcare professionals, which is that increased access to care supports adherence to routine HIV management. This is what we would expect to see and what we did observe. Because if you'll notice in the three tables, on average, women who went to the clinic 3 times at any point had lower average viral loads than women who went to the clinic just once. And so this is what we observe. However, due to COVID-19 lockdowns, even women who had increased access to care were still impacted and had increased viral loads on average. And so this really gets at the fact that the locus of control was removed from being in the woman's ability to show up and get care, but was placed in these kind of policy recommendations at the global and national and local levels that influence their individual health. And this is something that I think we need to think more carefully about as public health professionals in the future, and how we can create policy and recommendations that supports vulnerable people in these positions. And so that brings me to kind of implications for future research. The first kind of direction that I think is possible based on this work is to evaluate the impact of the decreased cervical cancer screening uptake in 2020 on the progression of pre-cancer and cancer diagnoses. And so, as I mentioned, women who fall into the living with HIV and at increased risk for cervical cancer bucket have a unique set of circumstances that require them to be in closer contact with healthcare professionals. But because that closer contact was interrupted by COVID-19, understanding long-term what that interruption did for their care is going to be very important for understanding incidence and mortality of cervical cancer in the near future. The second implication for future research is to assess how delays in accessing HAARTs impacted viral suppression and undetectable status for people living with HIV. As I mentioned, ARTs are really important for maintaining overall health and well-being for people living with HIV. Delays in accessing those medications can lead to increased viral load, which we saw in this study, but also that is reflected in a decrease in overall well-being and many other kind of consequences of that. And so understanding how those delays have impacted people living with HIV specifically is going to be very important, especially in high prevalence communities like Jos, like Nigeria, and many other low middle income countries. The third area for future research is to understand the interplay between delayed cervical cancer screening and increased HIV viral load for women living with HIV. And this is getting back to my earlier comment about how infectious diseases and chronic diseases often talk to each other apart from us as public health professionals who are observing and measuring their impact on the world. And so as the study has really demonstrated, HIV viral load increasing and then decreasing access to cervical cancer screening is kind of the perfect storm for increasing cervical cancer incidence in already burdened societies and communities. And so understanding how these two things relate with each other, even outside of COVID-19 and the disruptions that brought, is going to be very important for us in the near future in just preparing for future events like this. And the final thing is related to the comment that I just made, which is to determine how emergency preparedness and public health messaging can be tailored for low resource communities. And so as I mentioned in that very last finding, how an individual woman's viral load was increased, even though she was able to access care repetitively because of the global and national and local policies that were put in place. This really speaks to how we can serve underserved communities through our messaging around public health and emergency preparedness for future kind of public health events like this. And so with that in mind, I would like to kind of pose the question to you as a room full of public health professionals. What would you do if you were responsible for the communication around the next pandemic? We don't want one, but in the event that there is one, what would you do specifically in the messaging and communication to support communities of low resource settings that have high HIV burdens or high cervical cancer burdens or high whatever burden it is that you feel like is important for the world? And so this is a topic for discussion. And so if you want to like unmute yourself or like put it in the chat, I'd really be invested in knowing what y'all think about this.
Thank you so much.
Hi, can you hear me? Oh,
Yes.
go ahead.
Go ahead, Jennifer.
Yeah, go ahead.
I'm sorry. I'm a MPH student also, and thank you for your talk. This has been really interesting. I was just curious for future, pandemic preparedness. Your research really highlights the, sort of negative or just challenge that comes with these lockdowns and delayed care, but it doesn't necessarily look at, the impact of the actual pandemic and like the risk to that society, due to the virus itself. And so it's difficult to weigh, the benefits of the lockdown versus the risks of these care, delays or the risks of COVID. So I'm just curious how that should be framed. I don't have an answer to your question though.
Let me be sure I'm understanding.
I hope that makes sense.
So are you asking, I guess, like how do we go about weighing the benefit of, let's say, a citywide lockdown against the risk of delays to care? Is that what you're asking?
Yes, that's exactly it. Because, we don't necessarily, if we were to measure, how many hospitalizations or deaths were prevented due to the lockdown versus how many delays of, your research, which shows your delay of care and that sort of thing. How do we make those decisions when we are really trying to weigh those benefits and risks?
Yeah, that's a really good question. And the thing that first comes to mind for me is, how do you go about quantifying the benefit? In the sense that in the US, we were able to relatively quickly roll out some like COVID-19 testing, and there was a lot of messaging around how to do that. And people really took that upon themselves. But in Nigeria, there still is not widespread COVID-19 testing. There still are not accurate measurements for how many people actually have COVID. And that's in 2023, when, as I mentioned, people have been living post-COVID for about 2 years now. And so I think that while I think that it is an important question, I think that the level of priority, I guess, that question takes really does vary depending on where you are and the resources that are available in that setting. And so in a place like the US, we're able to do that assessment relatively easily because we know how many deaths were averted because people were able to stay at home, because people were able to have healthcare, talk to their doctors over Zoom, or like all of the different things, going to class on Zoom, going to work on Zoom, all of those things. We're able to do that calculation relatively easily. But in Nigeria, the situation is very different. And so the priorities there as far as how to prevent a disease that most people are not even convinced exists is much more abstract. And even I'd struggle to answer that question.
Yeah, that's good perspective, actually. Thank you.
Mm-hmm. Yeah. If there are any other comments, I'm technically not done, but I just have like a strengths and limitations slide. But here we go. So just really quickly to wrap this up, because I think I'm almost out of time. The strengths of the study are really that this is the first study that I have seen examining the impact of COVID-19 lockdowns on cervical cancer and HIV care in a low resource setting. Most of the studies have been focused in areas that have access to really rich data, which we were lucky to be able to have in this study. However, we're not really able to generalize these findings outside of people who are living with HIV. And so some caution is definitely needed there. All of this work was funded by the Global Health Equity Scholars Fellowship, which is funded by the NIH Fogarty International Center. And I would like to say a huge thank you to Madame Florence and Mrs. Olatunde at the APIN clinic who helped in identifying and abstracting these data, and to all of the marvelous co-authors on the paper that I got to work with in putting everything together. So now I'm officially done and I'm happy to answer questions.
Great presentation, Dr. Habila. And I would like to invite anyone who might have any questions. I do have one question, but I would love to invite everyone else.
Hi, my name is Coco, and I do know I've heard before that the cervical testing is basically kind of stopped, as you mentioned, at age 64. And I was just curious as to the message behind that, or why it's age 64.
Yeah. So I'm not a physician, so I'm going to answer this as an epidemiologist. And so I think the main reason why screening for cervical cancer is capped at 64 is that usually by then women are postmenopausal, and so they're not as sexually active. And because cervical cancer is caused by an STI, I guess the thinking is that they're less exposed to the STI. And so the risk of cervical cancer at that point is less just because of the decreased exposure. And so I think that's a huge part of the reason. And so then it becomes like a weighing of, not that women over 65 are like not valuable, but the value added of screening them for cervical cancer at that age is significantly less just because of their decreased risk. I hope that answers the question.
Yeah, basically, I will need to do my research, I guess, but I'm not sure in terms of HPV exposure, what how long it takes for cervical cancer to present itself. So if individuals have been exposed at age 50 or 40 or 30, is that too long a time frame that then they wouldn't be considered at risk for cervical cancer as a result of HPV, if that makes sense?
Yeah, the latency period for cervical cancer is about 20 years. So it's like 20 years from the like persistent infection with HPV to like a potential cervical cancer diagnosis. And so while your point is definitely well taken that someone could be exposed at like 55 and then like 20 years later have cervical cancer, there's always the likelihood of that. But the recommendations that are set forth by the American Society for Gynecologists and Obstetricians requires, or at least recommends, that screening is capped at 65. And so I think it does become a case-by-case basis after that. But again, that would be for a provider, a healthcare provider, to kind of provide guidance around.
Great. All right. Thank you so much.
I see a question in the chat. I don't know if you have access to it, or would you like me to read it?
Where is it? Okay. That given your research, what changes would you recommend for future pandemics?
Yes.
Okay. Yeah, that's a good question. And I think it kind of goes back to my answer to your earlier question, actually, which would really just be to evaluate the resources that are available within a context and not just have kind of broad strokes recommendations. Because as I mentioned, lockdowns were highly effective in the US just because there is infrastructure in place already to support everyone working from home, to the point where we are not battling COVID to the same extent as we were earlier in the pandemic, in the sense that we have vaccinations and we have masking and all of that is effective. But because we had supportive internet to begin with, we were able to all go online. Because we had kind of a very strong healthcare system that was able to stand up to the challenge of COVID-19, we were able to do all of these things. But the resources in a lot of low resource settings, they're called low resource settings because the resources just are not there to support that level of use. And so one example of something that's happening right now in Nigeria is, you've probably seen it on the news if you're paying attention to news in Africa at all. Physical currency has not been available. And so people are having to do purchases and transactions using the internet and like doing bank transfers. However, the internet is not strong enough to sustain all of those transfers. So people are literally at the market trying to buy produce for their family and trying to send money to the merchant and not being able to do that. So imagine trying to go to school in that type of setting. Like, that becomes very challenging. And so I would say that my primary thing would be to keep in mind the resources that are available and the structures that are currently in place, and work within those in order to support the community. Because oftentimes there's significant resilience at kind of the individual and community level. But if the policy recommendations are not built on those strengths, they will eventually then play on the weaknesses, and then people will kind of fall through the cracks.
That was actually going to be one of my questions. In recognizing that, yes, we have low resource settings. What, from your experience and with the research that you've done, what are some of the assets that some of the countries, some areas like Nigeria and JOS have to work in their advantage for the next pandemic?
Yeah, I think this could be said of a lot of these settings that scientifically we call low resource settings, there's very strong interpersonal relationships. People have very strong social networks. And those were a lot of the networks that people relied on to get food to their families and all of these different things to take care of needs. And so I think that is kind of the foundation for not just kind of going about preparing for emergencies, but also like how you share information. People who knew physicians, for example, were able to ask their physician friends, like, hey, is COVID really that serious? What do I need to do to protect my family? And as such, we're able to get reliable, scientifically based information, whereas people who didn't have those same rich networks were not able to have access to true and valuable information. So I would say these social networks that exist are a huge strength. I think that there's also an army of trained nurses and not quite healthcare professionals, but like community healthcare workers who work very hard in kind of prevention of malaria, measles, and other infectious diseases. These networks of people are also a significant strength because there's many of them and their skills are so many. And so being able to build on, I think, those two pieces in just thinking about how to prepare for future emergencies and just how to go about routine HIV prevention and cervical cancer prevention, relying on these two resources, I think in the future would be very effective because we know that they work already.
We probably have time for one or two more questions if anyone is interested. Well, if we don't have any more questions, I just want to thank you, Dr. Habila, for such a wonderful presentation, much needed research for sure. And on behalf of the Global Health Institute, the Global Health Programs, and of course, the Global Health Alliance, we want to thank you for giving us your time and sharing this very important study that you did. I also want to thank everyone who had the opportunity to join us today. Thank you so much for, I know everyone has a busy agenda. And I want to invite everyone, we will be sharing the links of our website where you can access this presentation and any of our previous presentations from the Global Health Speaker Series. And I also want to invite everyone to our next speaker series event, which is Monday, March 26th. And we will welcome Dr. Elizabeth Petit, who will be presenting about vulnerable cross-border populations and limited resources. So thank you so much again, Dr. Habila.
Thank you so much for having me, and thank you all for joining me as well.
Thank you. Have a great day, everyone.
Bye.